I'm going live, Chairman. Thank you.
Nick. Right, let's start. Hello, everybody. It's really nice to see you all. And I'd just like to begin with welcoming those members of the public and press who may be watching the live stream of this meeting via the Council's website. And members, we're all aware now the need to keep your video camera switched on for the duration of the meeting, unless there are technical issues, and please keep your microphone muted, except for when I invite you to speak. Please click the raise blue hand function if you wish to ask a question or make a comment. As we all know, there is always a risk that we may run into technical problems. I would ask for your patience if we do. Should this occur, I will declare an adjournment while the fault is addressed and the public broadcast will be paused. If it is not possible to address the fault, then the meeting may be abandoned until such time that it may be reconvened. And can I also remind you, please, members and our officers and any speakers we have, that all virtual meetings will be recorded and these recordings will be published on our Council's website. Members, can I please begin by calling the names of all members of the committee to establish your presence? Please unmute your microphone and be so kind enough to confirm you're present. Thank you. Councillor Connor.
Present.
Councillor Dupre.
Present.
Councillor Hay.
Present.
Councillor Harford.
Present.
Councillor Jones.
Present.
Councillor Nessinger. Thank you. Councillor Goldsack.
Present.
Councillor Smith.
Present.
Councillor Van der Ven.
Present.
Thank you. East Cambridgeshire District Council Representative, Councillor Ambrose Smith.
Present.
Fenland District Council Representative, Councillor Clark.
Present.
Excuse me. South Cambridgeshire District Council Representative, Councillor Harvey.
Present.
Cambridge City Council Representative, Councillor Massey.
Present.
Huntingdon District Council Representative, Councillor Taverner. Jill, you there? We'll move on. And myself, Councillor Hudson. We go to agenda item number 1, please. Can I ask Dan Snowden, please, to update us on any apologies?
Thanks, Chair. Just the one apology received from Councillor Reynolds, and
Yeah.
Councillor Goldsack is substituting.
Yeah, thank you, Mark, for jumping in so quickly. It's very appreciated. Does any member wish to declare any disclosable pecuniary interest or non-statutory disclosable interests, please? Good, and we'll move on. Item 2, minutes of the meeting that was held on the 6th of August. We are being asked to approve the minutes of the meeting held on the 6th of August as a correct record. Can I ask if any member does not agree with this proposal to please use the raised hand function now? Thank you. There are no raised hands, so on that basis, we are happy to approve the minutes, and I will sign the hard copy when that wonderful day finally arrives, when I can actually walk in the office and sign it. So thank you. Going on to item 3, Health Committee minutes and action log. The next item for noting is the minute action log. Can I ask if there is any further updates to what has already been included on the version we have received, please? No?
I'm not aware of any further updates, Chair.
Thank you, Liz. Has any members any questions they wish to raise on the minute action log? And if so, please raise your blue hand function. Yeah. Susan.
Thank you, Chair. The very last item on page 4 of the report, which is item number 8, Public Health Grant Tackling Obesity. I think that we may have gotten a slight muddle in terms of what the committee requested and what has happened so far. As I recall, we agreed that there needed to be some blue sky thinking on this matter, and it would be discussed at the advanced chairs briefing, which we did. But I think we didn't formally set up a task and finish group. We may have sort of gotten ahead of ourselves here because it hasn't actually come back to committee, and I think it needs to do so if I understand the governance correctly. So I just wanted to bring that to attention because I think that needs correction. Thank you.
Thank you. Liz, do you want to come back on that at all?
Look.
I think Val Thomas wants to come
I'm
in.
sorry.
Yeah.
Okay, thanks.
Oh,
I'm sorry, Val, I didn't see you.
No,
I
that's
do
all right.
apologise.
All right. It's okay. Yes, I think the agreement was, and I think Councillor Hay was going to lead the group, a small group of members to look at it. And I think the problem has been setting up a meeting, and I think Councillor Hay was off for a little while as well. And Kate is in the process of setting that meeting at the moment, as she has identified some dates. And I did communicate with Councillor Hay about it as well, about the delay.
Thank you. Susan, you happy with that? Okay, come back. Please.
I guess I probably didn't. I should have focused more clearly. I think the issue is the governance, to set up a task and finish group. I think the committee needs to do that, whereas we've only had an informal discussion at advanced chair's advanced meeting, or whatever we call it.
We spoke about this last meeting, and I'm sure we had volunteers because we did the same last year when Chris was vice chair, and Anne volunteered, and people like Linda Jones volunteered. I'm sure I'm right. Anne, would you like to come in? And, yeah.
Yes, I contacted Councillor Susan van der Ven, I contacted Linda Harford, and I contacted Linda Jones. And I did apologise because I should have asked them at that particular meeting whether Linda Jones and Councillor van der Ven were willing to come on there. I assumed they would because they were two of the members that spoke in favour of this. And I took it that I, as chair, could go and approach members to come on to this small working group, which is exactly what I've done. And yes, we have requested a meeting, but due to various problems along the way, it hasn't yet been decided what date we're going to meet, but I'm hoping it will be soon.
Yeah, it needs to be as soon as it possibly can, really, because we need to actually decide where this funding is going, so the committee can endorse that. Yeah, thank you. Councillor Jones, do you have something to say on that subject? Linda?
Sorry, yeah, I beg your pardon. Well, I was just going to say that I think the point that Councillor van der Ven is trying to make is that, and I think you've actually done it now, is that in a way the membership of the group should have been reported back to the committee. And I think now Anne has Councillor Hay has identified the members of the group are. I think we've all agreed we're happy to serve on the group. So I think if that's recorded in the minutes, we can now go away and do the work. I think that was the point she was making. It was a governance point.
Yeah,
I mean,
okay, that's brilliant.
Arguably, be people who objected to us being on the group. So I think that's the point.
Who could possibly object to you being on the group? Okay, thank you. Councillor Dupre, please. Lorna?
Thank you. Yes, I mean, the point I was going to make was that the minutes do not, on this, I've got a couple of other points as well in the action log, but on this point, I wish to say that I don't see it anywhere in the minutes, the suggestion that a task and finish group would be set up, let alone who would be on it. So I do think that if a decision has been made, it needs to be minuted. And if a decision has not been made, then it can't really be progressed outside this meeting without the authorization of the committee. So the minutes seem to me to be at variance with what is now being said. And I do think that needs to be tightened up. If the minutes do say that we're establishing a task and finish group, then I'm happy to have that pointed out to me, but I see no reference to that at all in the minutes that we had. The other 2 points I wanted to make was that in the action log on the top of page 14 of the agenda bundle on arranging members meetings between members of the committee and the CCG, in 3 other places in that row, it talks about meetings with CCS. Now, I don't know whether that's the council's defunct cleaning and catering service or whether it's something else, but I'd be grateful for clarification of whether this is the CCG or some other body, because that's one of those has to be incorrect. And the second point is on the local outbreak control plan at the top of page 15. There was an action for a structure chart to be provided showing diagrammatically how the various bodies interacted. And the notes say that the outbreak control plan has been put online, which I looked at and followed it up. And on that page, there are two documents, one of which is 14 pages long, the other is 29 pages long. The longer document does have a diagram in the middle of it, but I think if what we're asking for is a simple schematic representation to be made of who's doing what, then two documents totaling over 40 pages is not really the simple explanation that we were looking for. And I wondered whether promoting the diagram separately, if possible, might be a better idea. But at the moment, all of that looks very thick to wade through unless you have really serious interest in this.
Okay, thanks, Lorna. Thank you, really good. Liz, could you please come back to explain the relationship with our friends of the CCS and they're not the CCG?
Yes, and apologies that it's an acronym rather than the full name, which is Cambridgeshire Community Services NHS Trust. And that's the trust that provides the health visiting, school nursing and sexual health services together with some other services. It's a slightly complex relationship with them because we are their commissioners for a number of public health programmes, but also they provide some NHS services that are commissioned by the NHS, which you would therefore scrutinise as a in your health scrutiny role. But that is the organisation, and that's what CCS stands for in this context, and we'll try to avoid acronyms in future.
So it's the first cell that needs to be corrected.
Yeah, okay.
Yeah,
so that's fine, we can correct that. And yes, in terms of the diagram, quite happy to extract the diagram and circulate it to the committee. You're quite right, you do have to wade through a lot of the rest of the plan in order to find it, so very happy to do that.
Thank you, Liz. Dan, sorry, you're there? Dan, you got your hand up.
Yeah, thank you. Just going back to the establishment of the working group, task and finish group, whatever it is. If there's an agenda item later on, which is appointments to outside bodies, internal advisory groups. So if the committee is content to establish this group and appointments to it can be done under the delegation which exists there. So I'll minute that the committee is content to establish this group, and then if I can have the nominees outside of the meeting, then that can be done under the delegation.
Thank you. Councillor Hay will send you those nominations, yeah?
Thank you.
Okay, great, thank you. Lorna, your hand's still up. Have you? Lorna, your hand's still up. Your blue hand.
Removed now, Chair.
Thank you. Very kind. Thank you for those comments. Can we go on now, please, to the next item? It's petitions and public questions. There are no petitions for this meeting, and there are no public questions. So we'll move on to the next item, please. Scrutiny. We've got some scrutiny items. They're really important. And I know the people kind enough to leave their very busy NHS jobs to present these scrutiny items have to attend other meetings later today. It's the whole of this afternoon is all very, very tight. So can I please ask all presenters to keep their introductions short and to just highlight the key points in the report, because every single member of this committee has fully, as they always do, fully read the papers, and they'll be wanting to ask their questions as soon as possible, please. So question 5 is the Cambridgeshire and Peterborough Foundation Trust, the response to COVID-19, and our good friend Tracy is here. Tracy, thank you very much for attending. We very much appreciate you accepting the invitation and taking time out of your schedule to come today. I know how busy you are. I tend to limit the duration of this item to around 25 minutes because I ask the committee to bear that in mind, please. And Tracy needs to leave no later than 2:10. So Tracy, could you please give a short introduction?
Thank you. Very nice to see you all. It's been a long time.
Too long, yeah.
So lovely to see you all again. So it has been a busy number of months, both within CPFT and, at least as importantly, with our partners across the health and the care system. I won't go through the detail of the paper, given the assurance that everybody has read the paper. I hope it gives you sufficient detail, both about how within CPFT we have run the incident and continue to run the incident internally within the organisation, how we have and are in the process of very actively learning from our experiences in wave 1 as we prepare for either a second wave or for whatever comes our way over the next number of months, particularly in line with winter as well. And I think that learning is vital. I've included a little bit about the data about how our patients and our staff have been affected by COVID, and I'm happy to respond to that. I've also included information about staff wellbeing, which is absolutely critical and continues to be, especially given how brave and courageous staff, frontline staff, have been, but also actually back office staff as well, who have had to bear an awful lot of change in how they work and what they do over this period. I've included a little bit about the charitable support, which has been so welcome and has made such a huge difference, and a really important section about the impact on services and the work that we've got in place now, where we've got the very vast majority of our services fully restored, but we are delivering services in ways that continue to be COVID safe. And clearly we've got a lot of concerns as we go into winter, both about increases in COVID cases and presentations again, and not just the care of the patients with COVID, but being able to continue to meet the needs of the people who don't have COVID, but require the support of our other services. And I'm sure you'll want to talk about what's called in the NHS these phase 3 preparations and the part that CPFT will play in our health and care system over the coming months. I think you might be on mute.
Yeah, sorry. Okay, if you've got a question, guys, please raise your blue hand and I'll get to you. I do apologise about Linda Jones.
Thank you, and thanks very much, Tracy, for this really interesting and helpful report. Just a few questions, really. I mean, there's all sorts of things we could talk about, but I'm interested, first of all, in the numbers that were treated. And you talked about 72 COVID patients being treated. And I just wondered, did you send any to Papworth? And if so, how many? So that was sort of one question, because I'm on the Council of Governors of Papworth, and they were talking about having received patients from elsewhere in the system. And I wondered how that, how the accounting was being done, really. The second area of comments was in section 2.3, because you've got that really interesting section on organisational learning. And you raised there some of the challenges you'd learned about. You talked about the comms overload, you talked about the speed of redeployment, you talked about the caseload backlog, and you talked about PPE. And if those are situated in your paper as challenges, I wondered how far you felt it was within your remit to be able to respond to them, and how far you felt effectively to respond to those. And the third issue I wanted to ask about was the impact on service delivery. One of the things you talked about was shifting ways of operating and so on, which is really very interesting. I mean, a lot of the other hospitals have talked about doing more online and doing more remotely. You have a section talking about training care home staff, which I thought was particularly interesting. And you use the example, I think it was an example, of teaching them to administer insulin. And I just wondered how far there were other areas that you had already or were considering teaching care home staff, because I know one of the issues has been about the area of competence of care home staff and professional competence of care home staff, and having to call in GPs or specialist nurses or whatever to do things that with training they might be able to do in-house, and that might make for a more effective operation. So those were the sort of three areas.
Thank you, Linda. They're super questions. So in terms of did we send any of our patients to Papworth, I don't think we did send any of our patients directly to Papworth. We did have a number of patients who we received from other hospitals because we provide the rehabilitation post-discharge. So the vast majority of our COVID patients were coming to us already with a positive diagnosis, but they had recovered from the acute phase of that illness and were coming to us for rehabilitation. So the vast majority were in the stage of recovery and moving home, but there were a small number of patients, I could look it up for you, I don't have it at my fingertips, who we did refer back into the acute hospitals, to Peterborough, Hinchinbrook or Addenbrooke's hospitals, because they deteriorated and needed that support. Sometimes that was for a very short period of time and then they came back to us, and sometimes they then stayed within the acute hospitals and progressed from there. But I'm not aware that we admitted anybody directly from any of our rehabilitation wards into Papworth. Your second question was about the organisational learning and some of those challenges. And actually, I think an awful lot of that is within our remit. So real value from doing this organisational learning piece with our staff. In terms of the communications, our communications team did an incredibly good job and changed the hours that they work, 7 days a week. We do something called Talk to Tracy. I've just done my 30th one now through Teams to all staff. Staff bulletin every single day, all the way through, including weekends. There was a need to provide lots of communication, and you will know as well as I do that the guidance and the messages were changing as we learned about the guidance, and it was really important to try to keep everybody up to date because they had to shift practice very quickly, and to do those communications in ways that were as least confusing as it's possible to make them. And sometimes those messages are very complex. So to give complex messages in simple ways is a huge communication skill. We've had an enormous amount of feedback from our staff that they felt well communicated with, but that there was lots of it. And particularly for frontline clinical staff who were with patients, not in front of computers, we needed to make sure that they were getting very good face-to-face briefings from their ward managers every day, every shift, that there was really good handover so that we didn't rely on people being able to be in front of things that they could read by way of communication. So we've learned as we've gone along, but that is within our control. The biggest thing for me was around the redeployment of staff. When we went into wave one, we moved really quickly to discharge as many people as possible from our acute hospitals, because the vertical straight line growth in the number of COVID admissions to hospital, quite frankly, meant that we did not have time to consult with staff and talk with staff. We had to act, and it was at a time when we had had very little experience of COVID and knew a lot less than we know now, and staff were incredibly accommodating and brave, and did move to wherever we needed them to work, particularly to support discharge to assess, which is the title given to actually moving people from the hospital setting into a home or a rehab bed or a care home really quickly, and then undertaking those post-acute assessments that used to be done in hospitals now in the community. And we moved hundreds of our staff to support that acceleration of flow out of the hospital sector. And some of that we got very right, but some of it actually we didn't get so right. Staff felt a real sense that sometimes they were being asked to undertake roles that they didn't feel sufficiently comfortable with. So we had to invest a lot in giving them training and support. And many of our staff have reported something that the psychologists term moral injury, which is where they feel deeply affected by not being able to provide the services that they're trained to do for the patients who did need their care, but the risk of seeing them face to face was greater than the risk of not looking after them for a time. And I can't underestimate how hard staff have felt that. And so we've learned from that in terms of, should we need to redeploy staff as we go through the winter? Actually, I think we will take a bit more time about it. We will make sure that staff have some involvement and some say in where they work and how, and for how long. I do think that we probably would not be stopping the provision of the volume of community services that we were instructed to do nationally in a second wave. And I think there's a number of reasons for that. And one of those reasons is that I think the population's health can withstand not having some of those services for a period of time. But to do that twice in such quick succession, I would be really concerned. We'd have to really assess what the harm from not delivering those services is compared to the risk of COVID. But I wouldn't rule out redeploying again. Yes, Councillor.
Yeah, that's great. Thanks very much. We need to move on if we can. We've got several questions and time is running out really quickly, but that's really good questions. And I'd just like to say, I thought it was a fantastic paper. Thank you. Councillor Hay, please.
Hello. Yes, I've got 3 questions really.
Quick ones, I hope.
I'll try to
pick my answers.
2.51, the older people and adult community services, including older people mental health. Top of page 23, you mentioned complete suspension of step care therapy, memory assessment service, tissue viability, falls, etc. You also mentioned reduction in service in accepting only urgent critical referrals for over 10 county-wide specialist services. This paper obviously was written some time ago. Have these services started to be reintroduced, is my first question. And if they have, when can we see it get fully back to normal? If you have any idea on that. Also like to ask about the closure of Doddington and Wisbech MIUs. If I'm not mistaken, is Wisbech MIU now open again? And if not, when can we expect to see it open? And more importantly, when can we expect to see Doddington open? Because I know that's still closed. And my last question is to do with 2.53, children and young people mental health services. Mentions neurodevelopment referrals have been extended wait times because many of the diagnostic assessments need to be undertaken face-to-face. So there have been delays and we are still working to address this backlog and to find COVID-safe mechanisms of undertaking these assessments. Are we actually undertaking any face-to-face? And if we are undertaking any face-to-face, what sort of percentage are we seeing and what are just going on the back burner on the waiting lists? It also concerns me because it mentions we did see a reduction in referrals to CAMHS, and you've been able to significantly reduce wait times. But reduction in referrals could well mean people aren't presenting early enough and could be storing up trouble along the way. When they do present, their problems are going to be so much worse. Thank you. They're all my questions.
Thank you. Thank you. Please keep the questions short if you can. I think if I'm right in saying Wisbech is open and you hope to open Doddington in the autumn. That's a report I put out a couple of weeks ago. I'm sure that's correct. So that would answer that, Tracy.
So Wisbech is open, not quite the hours it was before. Ely is fully open. Doddington isn't open yet, and it very much does depend on what happens both with staffing and also with other services we need to support over this winter period. So we don't yet have a date for reopening Doddington, and I don't know if Jan also might want to come in on that as well, from the CCG perspective on that. We do have to make sure that the minor injury units are staffed to a really safe level given the capacity. So we won't be able to reopen all 3 for the same hours that they were before until we've got that level of enhanced staffing with the infection prevention and control. I don't know if Jan wants to come in on that or if you want me to move on to the other questions.
Move on, please.
Yeah. So in terms of older people and community services and older people's mental health, all of those services have now been reintroduced. I won't say that any services are back to normal, because I think what we're back to is a new normal, dreadful phrase. So many of those services were being delivered through digital means if we can, but if we have to see people face to face to be able to undertake the assessment or deliver the treatment, then we are doing that. But our older people clinicians balance the risk of seeing somebody face to face against and potentially spread of the virus against the benefits of that, and that they're very good at that. Children's mental health services, particularly neurodevelopment, referrals have dropped for all of CAMS, but we expect there'll be a surge in referrals now schools are back, because lots of the referrals come from schools, and that's why they reduced, and we have been able to get some breathing space. I can't give you the absolute percentage for neurodevelopment of what's face-to-face and what isn't, what's digital, but where we need to see somebody face-to-face, we can use PPE, and we will do that, and it's about that clinical benefit compared to waiting assessment that the clinicians do, and often in partnership obviously with the families, and now schools are open with the schools.
Thank you very much, Tracy.
Tracy, thank you. Just going on about the minor injury unit, I'd just like to say that Winch Beach reopened on Monday the 17th of August, Monday to Friday 8:30 to 6, with X-ray service available from 9 to 5. The opening hours of Ely Minor Injuries Unit remain extended from pre-COVID opening times, as in 8 in the morning to 8 at night, 7 days a week, and that happened from Saturday the 1st of August, with X-ray services available from 8 to 6. Plans have been worked on to reopen Donington during the autumn or when the situation allows. So that's hopefully covered that, yeah. Linda Harford, please.
Thank you, Chairman. I'll be as quick as I can. Thank you very much, Ms. Dowling, for this excellent report, which I thought had a very positive tone to it, despite some significant challenges both having been encountered and being faced by you in the future. I'd just very quickly like to refer to objectives 2 and 13 in that connection. It seems that you're doing some really good things, and if you have belief in what you're doing, I really believe you should allow it to benefit others. And I'm not just talking about other parts of the local CCG, but also nationwide, because where the learning from where your learning is good, you really should share it. And also I wanted to understand how you're learning from good things that are happening in other parts of the country. I have recently read of an initiative by Hampshire County Council with regard to testing. It may be overplayed in the article, but and just be another version of what you're already doing. But may I suggest that it might be useful at least to explore things like this. The next thing I just wanted to ask about was, is a bit along the lines of what Councillor Hayes said, but slightly different. The use of virtual methods for treatment, you say that recovery rates have not been impacted. I'd like to know if that's percentage wise, because you've said that volume decreased and is now picking up again. And that may indicate a totally different type of user, someone who's not happy with technology, which is why they hadn't contacted you previously. And how much reliance are you going to have on virtual treatments going forward? I think you've possibly answered that. So I'll skip over it because the chairman will slap my wrist. I've also looked at paragraph 2.6. It says planning also includes how you're going to invest in mental health services, including specialist services for children. The recruitment ambitions for you to be able to invest in the future are laudable and extremely necessary to support some equally ambitious plans, but how do they stack up against things like the availability of appropriately skilled people and what's being done to look at other sectors where there are huge job losses to identify transferable skills? Also, your past recruitment experience must indicate where the challenges in that lie. And what has been the effect of COVID-19 in terms of staff leaving the service? It would appear, at least anecdotally, that this may be happening in the care sector after their experience, and I just wondered whether it's affecting you as well. Thank you very much.
Thank you, Councillor Harford. So lots there. So in terms of the learning, we're both feeding into national learning. So our first response service for 111 has been adapted and copied across the country through COVID. So everybody has an emergency system similar to ours, not always through 111. I sit on a national mental health chief execs group to shape the national direction through to the learning. There are 6 of us on that. And we've been highlighted a number of times on calls around mental health and community services that are run by NHS England. So we learn from others, but we've also presented quite a lot of our work there and flown the flag for Cambridgeshire. The recovery rates within IAPT, what I'm meaning by that statement that they've not been affected is that we're seeing that the measured recovery of anxiety and depression through virtual means is as good as it is through face-to-face. But people can still have face-to-face, but our preference is virtual to keep both staff and to keep our patients as safe as we possibly can do. The investment in mental health services is hugely welcome, as we all know. The recruitment ambitions, we are being really successful in recruiting into unqualified posts where we can give people training. So we're currently recruiting a number of band 3, band 4 staff in both mental health and in physical health services for discharge to assess. And we are recruiting people from out of the health and care sector who have really good hospitality skills, and we can teach them the healthcare stuff. And actually they can teach us more as well about customer care. So we're doing really well in terms of that recruitment. Still challenges for specialist staff, and the area I'm probably most concerned about there is CAMS, where we are investing in more specialist staff in the CAMS crisis services and also in children's eating disorder services. And also adult eating disorder services with an exemplar. But being able to recruit sufficient highly qualified staff is a challenge, but we've got lots of plans to make us the attractive place to go.
Great. Thank you, Tracy. Thank you, Linda. Good questions. Yeah. We have 10 minutes left. If anybody cannot ask a question because we went out of time because Tracy has to go, could you please email that question to Kate, copying us all in, and then Kate will email whomever it is for a quick briefing on that subject, which will be sent around to all of us. I think that's the fairest way to do it. Susan, please.
Thank you very much, Tracy. I wondered if you could just tell us a little bit more about testing of trust employees. I noticed the number of tests, the COVID swab test is quite low compared to the antibody test. So I wonder if you could expand on that a bit, and especially the ambition or the regime for testing on a regular basis rather than a one-off, how that is set up. Thank you.
Thank you. So up until very recently, the testing was for staff who were having COVID symptoms and staying off, and we were able to access tests for staff in a timely way so that if that was a negative test, then they could come back to work. The antibody testing was made available to all staff. So staff who may have thought they may have had COVID, or just staff who wanted to know and were curious, could come forward for an antibody test. And we did find a rate of about 10% of our staff have been exposed to COVID and had an immune response to that. So they were different criteria for the different tests. Staff cannot just voluntarily decide, I think I'd like a COVID test because I'd like to know if I've got it now. And actually that has really quite limited value. At the moment, as you know, in the national news, there are lots of concerns about availability of testing, and this is particularly impacted upon because of the isolation rules. If anybody in your household has a symptom of COVID and is waiting for a test, then all of the family members need to isolate until that test result is back. And clearly there are delays for testing currently. The CCG, as part of our health system work, given that this is leading to a number of staff needing to isolate whilst they or family members are waiting for tests at the moment, the CCG is doing some really good work with our acute hospitals so that we can prioritise key workers or families of key workers, so we can get staff back to work as quickly as possible.
Thank you, Tracy. That's great. Nikki, please. We have 6 minutes. Nikki.
Okay, mine are very quick because some of
Good.
my questions have already been answered, so I won't bother repeating them. It was in regards to the phase 3 planning, including winter planning from flu immunisation for frontline staff. Have we also looked at offering vaccines for the most vulnerable, other vaccines, not just the flu vaccines, for the winter bugs that we know come every year and cause the pressures on our services? The other question was the amount of staff that went into shielding. Have you looked at the risk of, if we were to go back into a second wave, those staff having to go back into shielding, and what plans have you made to be able to fill or to be able to backfill their posts, etc.?
Thank you. So in terms of flu and winter, yes, our plans are well developed, and we are hoping to get universal flu vaccination of frontline staff this year, which would be a significant increase on all of our previous years. In terms of vaccinations for any of the other kind of winter bugs, I think that's really quite limited. So I'm not quite sure which vaccinations you might be meaning there. The only one that I'm obviously aware of is people who might be eligible for the pneumonia vaccine, which you only need once. So if you're an asthmatic and you're vulnerable to pneumonia, or you're of a certain age and you're vulnerable, if you're eligible for that, then people would be prompted to access that from their GP. But we do have to be really careful that we don't contravene the GP's role, and certainly with something like the pneumonia vaccine, you wouldn't want to give it twice. So we would direct people towards their GP. Similarly, if people might consider that they need vitamin D supplements, it's not occupational, it's part of their primary health care. Staff who are shielding and potentially at risk, we have done a personal risk assessment with every single one of our staff. So all 4,000 staff have had a sit-down personal risk assessment, and staff who are at risk, we have mitigating plans for them. If those staff who've been shielding, who are now back at work, would need for their safety to go and shield again, then that would be our priority, and we have got mitigating plans that we used during wave 1. That we can do that with minimal impact.
Thank you, Tracy. We need to move on now. The very last question. I'm glad I got you in, Lucy. We're very short of time, my dear, so it's all yours. Thank you.
Two very quick questions. The first is on autism and ADHD. It mentions that was paused. I'm hoping that that's up and running again, at least for diagnosis as well as for treatment. The other one was that I know that during the spring, there were cases where there were COVID patients with learning disabilities or mental health needs in care facilities where it was not safe to keep them in those care facilities. And I know of one case in particular where it was extremely difficult to find a safe placement for that person. And I know that he was then found somewhere at Fulbourn, for which I was profoundly grateful, but it wasn't till midnight. Are there now better systems in place for making sure that people who are diagnosed with COVID in placements where they may then be putting other residents at severe risk, that there are ways in which those people can be found suitable, safe places for them to recover?
So I'm not sure I'm probably best placed to answer on the specifics of those organisations that I'm not accountable for. What I can tell you is that if we need to join a case conference to find a suitable placement or to find alternatives, as we did in that incident, then we will do that. And we will, if necessary, go into different organisations to provide additional support and additional care. So during wave 1,
in that case, would you have said that it was the county who was responsible? Because it is really important to know where the responsibility lies.
So it depends on the different case. So I can't talk about an individual case, particularly when I don't have the details of it. It would depend on what the case was in terms of where the responsibility is. I think what matters in these instances is that we share that responsibility to find an outcome where there isn't an obvious one collectively and together that best meets that person's needs and keeps them safe. So for example, that might include us sending staff into that care home to support somebody and work with them. And we sent many of our community staff into care homes during COVID to find additional support, therefore, for those care home staff. And it is about us coming together as partners to find the best solution that meets the individual needs of that person and keeps other people and other members of that person's family safe. I don't, in those very specialist situations, there isn't a blanket answer. The answer lies in bringing all of those partners together with a shared mindset of finding the right solution. And I think it sounds like that's what we did in that instance, and I know there have been others where that's what we've done, particularly if somebody is in A&E and it isn't clear what the right solution is. We work together to find the best fit solution, and that means everybody compromises.
Thank you, Tracy. Thanks, Lucy. If you want to take that a bit further, we might be able to look at that in chairs, vice chairs, and lead members, because that's a really good question. Thanks, everybody. Tracy, as always, it's smashing to see you again. Thank you. Please pass on to your staff all our thanks for the great work they're doing. Thank you. Okay, item 7. No, it isn't. Item 6. Sorry. And yes, we welcome. Oh, it's Jan. Hello, Jan. It's nice to see you again. We all know Jan is the accountable officer for the clinical commissioning group, and she's with Louis Camphor, who's the CCG Chief Financial Officer. Very grateful of you all coming. I have to limit this, and you have to leave at 2:35. So that gives us 20 minutes, guys, please. Don't forget, if there's other questions you can't get in, email them into Kate, and we'll get the answer around, not only to you, to everybody else. Jan, would you like to give a brief introduction, please?
Mute. You're mute.
Jan, mute. Jan or Louis? Yeah, take your pick.
Yeah, got it. Yeah, sorry.
Hello.
You'd think I'd learned that now. 6 months in, you'd think I'd have mastered the mute, but no. Firstly, it's lovely to see everybody. Thank you very much for giving us the opportunity to talk about our finances again. I think I'm going to hand straight over to Louis, but just with the context of we had a few months there then when actually money wasn't at the focus of it, just uniting around COVID and really making sure that we could do everything possible to keep people as safe as possible was the priority. In the last 48 hours, we've just had information on the forward allocation. So just to give Louis, give you a heads up, we're still working through what that new allocation means, and the NHS financial regime has changed, but our challenges haven't changed and the pressures still haven't changed. So Louis, I think everyone's read the paper, so it's just the important bits that you need to just pull out for people.
Yes,
that's
please.
fine. Thank you, Jan, and thank you again for the opportunity to speak. So very briefly, I think our financial year is now kind of one of two halves. So for month 1 to 6, the NHS has been funded in a very specific way. We've been given an allocation at the start. We have been told very clearly to suspend all our kind of contracting and planning arrangements. We have been given very specific block payments to give to our providers. The centre has taken over the contracting with our acute sector, the independent sector, I should say, and we were told to continue to provide and to contract with all other independent sector contracts. There was a rapid discharge process put in place, which is probably the most important. The kind of continuing healthcare assessments, that whole process stopped, and all the people that were discharged from hospital that were previously the responsibility of either the CCG or health or the local authority were then paid for through this this kind of accelerated discharge process. We've then been given specific allocations around our COVID spend, and there was an expectation that we should break even as an organisation and certainly as a health system. Obviously, through that process, we've worked very closely with local authority colleagues, because actually everything we've done was absolutely linked through the first 6 months of this year. As we move on to kind of month 7 to 12, as Jan already said, there is an expectation that we will still have some sort of discharge process and discharge support, which will help fund people for a 6-week period post-discharge out of out of hospital or out of any other health settings. That's going to come down separately. And again, we're working very closely with local authority colleagues on that process. But for the rest of health, as Jan said, we've had an allocation published just yesterday, and a lot of guidance that came with that. And as a kind of health system, we are currently working through that to see the extent to which that funds us for the next kind of 6 months and what the potential gaps are and how we treat that. It's no surprise to anyone that there is going to be significant ongoing costs with regards to the COVID response, but more importantly, there's going to be significant ongoing costs around recovery. Given the current infection prevention control guidance that's in place, our providers has to do a lot of things that they didn't do before to get up to the level of activity that we were able to do last year. And that is going to come with, more hours working, 7-day working, additional costs, additional overtime, more staff required to try and get back to the level of activity we did last year. So there is going to be an ongoing cost with regards to that. And as Jan said, we're working through that at the moment. I was asked to also specifically talk about the debt write-off for the health system. So in April, there was an announcement that the NHS would have 13.4 billion written off. Just to confirm that is specifically for NHS providers. The CCG's debt has not been written off, and we still have about 133 million pounds of kind of accumulated debt on our balance sheet. But from a provider point of view, the process for that is that the debt essentially gets converted into what they call a public dividend capital, and that providers going forward, instead of paying interest on loans, they will be paying dividends on the public dividend capital, which is issued from the Department of Health and Social Care. So that's the kind of process that they've adopted. It is NHS providers, it's not the CCG, but just to clarify, because I was asked to specifically pick up that point. I'll stop there because I'm sure you've read the paper and happy to take any questions. Sorry, you're on mute.
You thought I'd be used to this by now. Thanks, Louis. That's really good. Very interesting. Lauder, please.
Thank you. I think, Louis, in that last point, just clarified the question I was going to ask about 2.4.1, where the report said that 13.4 million of NHS debt would be written off, but that the CCG's cumulative debt of 133 million still stands. I was somewhat perplexed as to how the CCG's cumulative debt could be 10 times the amount that was written off nationally. So I'm assuming that Louis was correct and that it's actually 13.4 billion that's been written off rather than the million.
Thank you very much for spotting that. Apologies, I didn't notice that. It is 13.4 billion, not million. It wouldn't be, we would be absolutely overjoyed if it was only 13.4 million.
Thank you.
Thanks, Laura. That's really good. Councillor Jones. Linda, please. Linda?
Yes, thank you. I realise you're still working through the allocation, Louis, but I mean, the situation you obviously don't want to get in is that debts are going to go on rolling forward, or rather new debts are. So can you give us any assurance that the allocation, given that it's quite likely that the spike of COVID through the winter is going to be significant, can you give us any reassurance that the level of allocation is going to enable you to cope? Or do you see a situation where you're sort of supposed to be returning to normal and catching up, and a spike, when, if it comes, will be separately funded? I can't quite understand the funding going forward.
So at the moment, we've been issued an allocation, and we are told that that allocation is there to cover our ongoing COVID expenditure, what would be our baseline spend, and any recovery. We as a system, like most other systems in the region, are currently working on what are we likely to spend in what would be the COVID scenario that we are seeing at the moment. What would the true cost of recovery be if we get back to the levels of activity last year within the existing infection prevention and control guidance, and what is our likely baseline expenditure likely to be? And at the moment, the allocation is not sufficient to cover that. we are absolutely not wanting to jeopardize recovery. I think, there's a very clear steer that, we should do on recovery what is operationally possible. But equally, with my finance hat on, I will say we also need to be very clear about what we're getting for the money that we're spending, and we really need to push our productivity, and we need to be reasonable about the additional spend that we can commit. And I think it's trying to find the balance between those two. Because obviously recovery is really important because we're sitting on clinical risk, and we need to get patients seen, and we need to get patients seen as quickly as possible. But we need to be mindful that we need to try and push through as much as we can within our existing baselines, our existing facilities, and be as productive as we can. And that, as Jan said, is the kind of conversation we're having as a system at the moment through, the finance group, but also very much through the clinical group and the chief operating officers of the system. Does that answer your question?
Thank you, Louis. Linda, do you want to come back quickly?
No, I think what you're saying is it's not sufficient, but actually, until we know exactly how things are going to pan out, it's very difficult. I mean, I guess if the situation gets really much worse, then the government will be inclined to, I was going to say throw money at it, but I don't mean it in that kind of, I'm not being, rude about it. I just mean they will do what it takes in order to cope with the peak.
I think that's right. And I think at the moment, what we're thinking is we are going to have probably quite a harsh winter. It's going to go inside with no doubt continuing COVID activity, and we've got to recover. So those things together is quite difficult operationally to deliver. And I think anything that happens, if we've got a significant COVID surge, a second surge, then that will no doubt put recovery in danger, and that will no doubt have a financial impact, as you say. So within the given planning parameters we've got at the moment, we think there is more work for us to do on the money to make it affordable. But equally, as I said, we are being told very clearly to not jeopardize recovery, but to push for productivity. It's the only way that I can put it.
Thank you.
Thank you. Thank you, Lewis. Last question, please, Susan.
Thank you. Thank you very much for that, and look forward to hearing what you make of it. We have there's an unrelated question, and I hope that you received advance notice of it, and if not, apologies. I just wanted to raise a question about CCG guidance to general practice on face-to-face patient support, and because I get the sense that there's quite an uneven picture across GP practices, and I wondered, what the guidance is for seeing patients in person. Thank you.
Jan, did you want me to answer? Did you want to answer that one?
You can give it a go if you'd like.
Happy either way.
Go on.
So I think the message at the moment is, and what our practices are trying to do, is to see everyone and make sure that everyone has access to primary care. And where appropriate and where needed, patients are seen face-to-face. I think what we have seen through the activity and the data that we're looking at is our practices are doing actually quite a lot more than they did last year in terms of the activity, making sure they triage patients, making sure they talk to patients, and making sure the patients get access to the care that they need or get onward referrals where appropriate. So I think our message has been very clear. We need to make sure that we do what's clinically appropriate for patients, and where a patient can be triaged over the phone and we don't have to put a patient or frankly a clinician at risk, then that's the right thing to do. Where a patient needs to be seen face to face, they absolutely will be, as Tracy said earlier, and exactly same in mental health, with the appropriate PPE, etc. in place. So I don't think our message is inconsistent to practices. Jan, I don't know if there's anything you want to add.
Yeah, so just quickly, I think we need to be very careful with primary care at the moment and GPs, because as Louis says, they're doing more than they've ever done before. They're doing it differently, primarily because they had to, and they are having to manage the flow into their practices differently. And there is a question about, do they have things like the telephony infrastructure to be able to deal with so many calls coming in and so many calls going out, etc. So there is definitely a practical element to this that I do think sometimes makes it hard for patients to access services. So, I think that is there, but there is, general practice is doing more than they have ever done before, and I think it's really important that we get behind them and make sure that in the cases where people are really struggling to get through, we're very specific about where those instances are happening and deal with those specific instances rather than generalising primary care, because we're very quickly, I think, careering into a real problem with morale in primary care, where the pressure is building and building, and they've held a huge amount of risk. And I really know that what we've got coming up, as Louis said, with recovery, with winter, with flu, and with COVID, we need them to be, keeping going. And there's been some stuff nationally going on that I think people might have seen this week that hasn't helped that. But we're really working hard to support our practices to make sure that they have what they need to keep going.
Thank you very much. That's really helpful.
Yeah, that's very good. Thanks, Jan. Thanks, Louis. Really, really big thank you for coming. It's really appreciative. And please pass on to all your colleagues our thanks for all they're doing. And see you again soon. Thank you.
Thank you very much.
Take care.
Thank you. Bye.
Okay, item 7, please. This is a briefing paper on response to childhood immunisation uptake during the COVID-19. We have our dear friend Raj, and also from our public health team, and Sheila Thompson from excuse me, National Health England. Sheila has to go before 3. Raj, I believe you're on call out, and Raj has to leave at 3 o'clock to attend to a COVID-19 outbreak management issue. Yeah, so if you could start and give a very brief introduction, Raj. Yeah, thank you.
Thank you, Chair, and thanks for inviting Shaila and me to this meeting. It's just to update on the system response to promoting childhood immunization, what the early data is suggesting, and what our approach to recovery and planning for flu has been. I won't go through the whole paper, just to say that we are responsible for making sure that our population is well vaccinated, because vaccination programs are very important in terms of health and economic benefit. The vaccination program is commissioned by NHS England, and that's why Shaila is here to answer any questions about the data, because we've got data in this paper for the period up to March, which is the last quarter of last year, and the data for this year, I've spoken to Shaila and she can briefly tell you what that is. The targets are more than 90%, and there was a concern that due to parental anxiety and some of the clinic closures, and children may not be going, parents may not be taking their children forward for immunizations. And WHO and NHS have all stressed the importance that this should happen irrespective of the pandemic. And in terms of what we've been doing so far, we've been having weekly meetings with Early Help, Healthy Child Program, and Public Health Commissioners throughout to monitor all the actions we need to take. In addition to childhood immunization, other issues that were being raised. We did do a questionnaire to check with what was happening in GP surgeries, along with our colleagues at the CCG. And the immunizations were happening at 8 weeks, and along with that, the newborn infant physical exam was also happening, along with the maternal mental mood review. So we were confident that this was going on despite the lockdown. We've promoted messages via social media. We've been promoting or checking through our Healthy Child programs records about immunizations and making every contact count with every contact that the health visitors had with these families. We worked very closely with our colleagues in education to get through in schools and early year settings. And we've also talked about how we can start the flu immunization campaign, flu immunization once the schools have restarted, because the school-based immunization program had to be stopped in March when when we know what happened. So in terms of, there was a question from committee about RSV vaccinations, and we did look up about it, just to say that it is an antibody vaccine, and the Joint Committee on Vaccinations has said it should be given for high-risk infants, and it's not a routine part of the UK immunization schedule. In terms of 4, what is the early data telling us? As you can see, this is the cover data that's publicly available on the website that I've pointed below. Cambridgeshire is doing over 90%, apart from one where we are 89.3% for the 5-year vaccination coverage for diphtheria, tetanus, pertussis, and polio. So I think we can be confident that in Cambridgeshire, things have gone well pre-COVID, and we had information from NHS England, which I've put in 4.4, that for Q1, when they look informally at the data, it seems to be okay. But I'll let Shaila take over from here so that we have some time for questions. Thank you.
Hi, thank you for inviting me to the Health Committee. I don't have anything more to add to what Raj said. It is, we have Q1 data is the data covering April, May, and June. So that is a period where lockdown happened. Childhood immunizations continued during lockdown. It did not pause or stop. Most of them are time critical, and to protect the population from vaccine preventable illnesses and the consequences from it, even death. So they need to be given on time, and they continue during the lockdown, and which is really good for us. In terms of what early data is showing, the cover data for Q1 will be published next week. It is good news that the standards have been maintained. For childhood immunizations, the standard of primary immunizations have remained at 95% at 2 years, and at 91% at 5 years. For MMR 2 doses. And for the school leaver preschool booster, it is at 89.6. So absolutely no drop in immunizations at all during Q1, which is really good news. And like I said, the data will be published next week on cover. This is the preliminary data I have got in front of me. And similar for Peterborough, no change in pattern at all compared to the previous quarters in previous years. For school-age immunizations, where the provider goes into school to give immunizations to mainly secondary school, year 8 and year 9, this is for the HPV vaccination for boys and girls in year 8, and a second dose in year 9, and the meningitis ACWY to protect against certain meningococcal infections, and school leaver booster, which is the TDIPV, given in year 9. This was paused when schools closed in late March till June, and when some schools, some years opened in June, so the Cambridgeshire Community Service, which provide the school-age immunizations, had to go into the schools to give some immunizations. They also identified certain community venues to invite children to clear the backlog and catch up, which happened in June and July, and continuing in September. So we hope most of the backlog will be cleared. The remaining will be cleared in early next year. All the school-age staff will move to school flu vaccination delivery between October and December. From last week of September, they will move to school flu vaccination delivery, which is to all the children from reception year, all of primary school years, and year 7 in secondary school. It is a big program because it has got to cover thousands of children over a period of 12 weeks. And
Okay.
they're all prepared for that. Yeah.
Can I just stop you there now, please? That's really, really good information. Thank you. It's a great report. And hopefully what we've heard from yourself and Raj will cover most of the questions that somebody may want to ask anyway. So we'll go to questions now, please, because time is against us. Lorna.
Yes. First question, what was the response rate of the survey of GPs? Second question, the figures for the first 3 months of this year, i.e. Q4 of 2019-20, suggest that there were already issues with vaccination coverage, particularly of the older children even before lockdown, which is of some concern. And I wondered whether you had any information at any more granular level within Cambridgeshire about where those particular issues might be and whether there were any geographical disparities within and between districts.
So I can see only the publicly available data, which is the cover data, but I don't know if Shaila or Liz have more granular information. We can see only the high level data.
So just
I can see publicly available
about the
data,
GP survey, I don't know, Raj, you said you mentioned you did the
GP survey. I will pick that up. Sorry, GP survey. Again, I will have to go back and look at the response rate. I think it was good, but I will have to go back and answer that question for you, Lorna, because it was conducted through our colleagues at the CCG. It wasn't sent out from us. It was sent out along with a lot of other questions that they had to ask them. We just asked some that were of importance to us. So it was part of a bigger survey. It wasn't just us asking these questions. So I'll have to go back to the CCG to unpick that data, and I can send that across to you, Lorna.
Thank you very much.
Yeah.
Coming to the issue of slightly lower uptake in the preschool booster and the MMR2 doses, that has been a historic issue with the preschool children going for those doses. It is well known. We know where those are because we look at GP level data and we contact those GPs and see what interventions can be put in place to improve uptake. Some of the actions we have done in the past and continuing is that we have commissioned the school age immunization service to check the immunization uptake in reception year and to offer the outstanding immunization, that is the preschool booster and the MMR second dose if the child is not had that dose at 3.5 years of age. So that is an intervention we have put in place. We have also engaged with communities to raise awareness to improve immunization uptake in this preschool booster and MMR2 doses. So these are the work we have done in the past. And we are still continuing to engage with communities and to do this work. School age immunization services still commissioned to do that check in the reception year.
Thank you. And if you get that answer, Raj, if you could send all the committee the answer as opposed to just Lorna, please, that'd be lovely. Thanks very much. Nikki, please.
Just really, I've got more comments than questions. So thank you very much for going back to look at RSV. As you say, it's a national guideline, so it's something that I'll push on nationally. I really do believe that the RSV vaccine would be better widely used, but that's a personal experience. In regards to the HPV vaccine, my son, again, he missed the HPV vaccine during the school because of COVID. We were sent another date in August, but we actually had to go some way away within the Cambridge city to get that vaccine in another school. So I do wonder whether there were some children who may not have been able to have made that journey and therefore hadn't taken that vaccine up. Coincidentally, I had pulled my son's leg and told him that we'd enrolled him on the COVID vaccine trial, which I thought he would have guessed that I was joking because why would I do that to my child? But he thought he was going to save the world. So I had to then tell him it wasn't the COVID vaccine. And then when we came back from holiday, we found an actual letter inviting him to be part of the IPOS trial for COVID. So I had to persuade him that one was real. So anyway, it was just a side note.
That's great, yeah.
Thank you.
In terms of HPV, I think, Shaila, do you want to comment? I think you have some put in measures for catch up, isn't it?
Yeah, it is because, like I mentioned previously, because schools were closed and the correct year group is year 8 or year 9 children were not back in school in June and July, the provider had to find alternative venues, which may not be as easily accessible in terms of travel distance, and they had to go to a distance. But because of the situation with COVID, there wasn't any easy alternative available in terms of venues where the schools are closed or not open to that particular school year. So I think one of my requests will be for Department of Education to communicate that to schools to allow the school age immunization team to use the premises for school age vaccination program, so that children may not have to travel longer distance to access the vaccination.
That's great. Okay, thanks very much for that. Lucy, please.
Thank you. So I also took my daughter in to have her HPV vaccination in a different school in the summer. And I have to say that under lots of this information in this report, I'm enormously grateful to the vaccinations team for carrying on with as much as they did during the lockdown. I was very impressed with the setup at the school that we went to, and it's not difficult to, I mean, it's not easy to suddenly have to reorganize everything that you're doing because there's a pandemic, and I thought that they did a good job. I'm sure we will need to look at whether catch-ups are needed, but I think that they did. I just wanted to say thank you for the work that was done, because I think there was an amazing amount of continuing with the process, which was really impressive. The thing I actually wanted to ask about was to do with winter flu vaccines, which we haven't really talked about very much this afternoon. So I think the first thing is I think there will be a much higher demand and many more people wanting to have a winter flu vaccine than is normally the case this year. And that there are very good reasons why many more people might want to have a winter flu vaccine than would normally be the case, because there's clearly already a problem with sort of normal, not quite flu, but so far coughs and colds getting muddled up with COVID. And then if you've got to isolate your family for 2 weeks because somebody has a symptom, the incentive to not get symptoms is huge. So my questions really are, how prepared are you for a huge desire from people to want to have winter flu vaccines this year? Has there been any extension of the people who are allowed to get one? Because I have a feeling that there will be very large numbers of people who want one, and I'm not sure that people are clear about who is allowed to have one and who isn't. And do we know what availability for those who are not able to have one on the NHS, which I think is a relatively restricted number of people? Do we know whether there are going to be private winter flu vaccines available, and will people be informed about where they can get them?
Yeah, so
I can answer that, Lucy, because in the paper I've got there is the link to what the eligibility criteria are for the flu vaccine. It's the last link on the paper. I can reassure you that we are having weekly meetings as an STP. So we joined the STP meetings. There's GPs involved, pharmacists involved, the school immunization teams involved, and care homes, everybody involved in the winter flu planning. There's regional oversight as well as local oversight. And we have a little children's team as well, children and maternity team, to look at the pregnancy and childhood flu. So 2 and 3 year olds will get it through their GPs, and the others who are in school will get it through schools. It's extended to year 7. So as you say, there's a much larger cohort who are eligible. And as I said, it's in that link, the eligible cohort. So it is a lot more doses. The target is also higher. And we are aiming in Cambridgeshire and Peterborough to achieve that target. We've been reassured that there is enough vaccine supply, but we've done a paper for the STP about prioritization and what we would do if there was at some stage a little slip and we had to prioritize. I don't know about the private, but the pharmacists and GPs and everybody are on our weekly meetings.
Just to add to that, yes, this year it is a massively increased.
Raj, wait, one person at a time, please. Charlie, you wanted to say something?
Just to add that this year it is a massively increased flu vaccination program with a lot of additional cohorts added. So we have all the children 2-3 years and the primary school and secondary school year 7. Then all the people over the age of 65 years, the under 65 at risk, who will be offered the vaccination early. and the target is 75% uptake, which is quite a high standard that is being set this year. And once the at-risk people are all offered the flu vaccination, the plan is to move to offer 50 to 64-year-old healthy people from November onwards. So ultimately, half the population of the country, like 30 million, will be offered the flu vaccination this year. It's such an expanded program this year, which means a lot of people can benefit from the flu vaccination this year.
Can I just come back very quickly? I think that's incredibly helpful. And I'm really clear about that the 50 to 64 age group will be offered it this year. That's a very, very large number of people. I just wondered whether there was any sense in which there might be priority given to key workers or teachers, because there are some groups in the population who are more at risk because they see large numbers of people. I mean, actually, bus drivers are a really good example, who it would be helpful if they got a certain amount of priority. Is there any sense that that's happening?
Not at the moment. So all the people who are at greater risk from flu are the people with underlying health conditions, and they will always be invited first in late September, early October. So any person, school teachers, bus drivers, key workers with an underlying health condition that makes them more at risk from a flu infection, like heart disease, asthma, diabetes, respiratory condition, they will be invited first. The healthy people in the 50 to 64-year-old age group will be invited in November, depending on vaccine supply. This is to ensure that all the at-risk people who are of higher priority is offered the vaccination first in October. And depending on the vaccine supply, the healthy people will be invited from November onwards. So that is the priority order for vaccination.
Thank you.
Yeah, thanks very much indeed. We must move on. Thank you. Mark, please.
Yeah, I'll try and keep it quick, but it does follow on very much from Councillor Netsinger's comments. My wife has been in lockdown and is a vulnerable person, and she's been invited to have her flu vaccination this year at a local community centre as opposed to going into a medical facility. I think that's a brilliant idea in bringing that particular vaccination out to the public, and I think that I would encourage that as a better idea to help you improve on what's a very good set of numbers and a nice report that you've delivered today. But I think actually creating a separate environment, school is a great one, but if anybody's missed or doesn't get it at school, then actually avoiding going into places of multiple people coming in in health environments. There's an awful lot of nervousness out there at the moment about doing that. So coming into a local community and doing it in a community centre is probably a really good option. I'd just like to know whether that's the plan.
Thank you. Yeah. Thanks for that. Yes, thank you.
Yeah, there is all sorts of venues will be useful to use this flu season because of the large number of people who require flu vaccination. And yeah, any suitable venue is being identified to be offered vaccinations this year.
Thank you. Are you happy with that, Mark? Yeah.
Well, it doesn't really answer the question, but maybe I should have phrased it a bit differently. Listen, I'm glad that other buildings are being used and that we're not encouraging multiple droves of people to be going into health centres and places of high traffic of ill people. Because at the moment, as somebody else said, I think it might have been Lucy said, a lot of people are confused and a tickle in the throat or a sneeze and going and getting a COVID test. And we don't want to be in those environments if we can avoid them. Thank you anyway.
Absolutely. Thank you. Linda, please.
Thank you. I just wanted, thank you very much for the report, and I'm really pleased to have the flu issue dealt with as well. I think as Raj can tell, the committee is very concerned about immunisation, vaccination issues in relation to children in particular. I'm just thinking that one of the things we haven't got in this paper, except for some helpful speculation from Shalala and from you, has been what actually happened during the first wave, as it were, of COVID. And it would be really helpful to have another paper coming. I know this is for the advanced agenda, but I wanted just to flag, have another paper coming perhaps early next year when we understand more about what that first wave meant in terms of the trends in vaccination.
Yes.
Yeah.
Raj, do you want to mention
Yeah,
that?
thank you, Linda. Yeah, thank you. We'll pick that up when we have more data and about what happened during. Thank you.
And we will take that forward, Linda. You can even pop it on your list for the next chairs, vice chairs, lead members meeting. We'll discuss it, where to put it. Yeah, thank you. Okay, Raj and Shayla, thanks very much indeed for coming. It's just before 3 and you both have to rush off. Best of luck, Raj, where you're going for your outbreak issue. Keep yourself safe, please. Thank you very much.
Thank you.
Thank you. Thank you. Thank you.
Okay, item 8, please, members. Pages 49 to 54, I believe, is the public health and environmental health response to COVID-19. And we have our very own Val, and she's accompanied by Yvonne O'Donnell from Cambridge City Council. And this has to be finished by 3:20 because Yvonne has to leave for further meetings. We have this paper because of people like me, and I suppose I should add, before you start, Val, with your very brief introduction, that some of this paper, since the new instructions come in on Monday, so some of this has changed slightly. It was mainly places of social interaction were not all complied with the track and trace advice, and we got quite upset about that. But now they legally have to do it. So anyway, I'll pass it back to you for a very quick introduction, please.
Okay, thank you, Councillor Hudson. Very briefly, as you said, this is paper of information in response to your request. But I think briefly to give an overview, in terms of the environmental health services provided by our districts, they play an integral part in our local outbreak control plan, not only in terms of being part of the Health Protection Board, the programme delivery group, but also playing very active roles in a lot of the cells who are dealing on a day-to-day basis with outbreaks. I think most notably, I'll just flag up a few key areas I think, which are in the paper, but I'll just deal with them very briefly. Each district has a response team, which provides a variety of actions in response to an outbreak. And the single point of contact for that team is the environmental health leads, and they play a key role then in orchestrating and activating actions. And that might be a whole range of actions, working with different teams within the districts to ensure that they respond appropriately. Secondly, environmental health services have a long-standing statutory responsibility in relation to outbreak controls, with a particular focus on certain workplaces. And that knowledge and experience of dealing with those settings, but also their local knowledge of their districts is extremely useful in outbreak management. And they work as this, particularly in relation to workplaces, and as part of the workplace cell, they are very active in their districts in terms of working with a lot of employers in terms of helping them to do risk assessments to ensure that their workplaces are safe, COVID safe, and providing a lot of information. They communicate with them on a regular basis, but I'll leave Yvonne for any details in this. And alongside that, as well as those more traditional roles, Yvonne in particular, who is the lead who's identified as the lead environmental health officer, and she speaks on behalf of all the districts and works on their behalf. She also is the joint lead of the workplace planning and training group, which has been absolutely critical in terms of planning and response to well, the anticipated surge that could happen over the next few months. So I think there's much more to that, and Yvonne can obviously talk about it at great length, but I think those are the really key core things, and also taking part in those overarching governance structures as well, which are obviously play a role in our local outbreak control plan. So I'll hand over to Yvonne.
Thanks, Val. Yeah, so we've been working very closely with our colleagues in public health, as we have done for many years, but especially in the current climate, where we've had to carry out quite a lot of enforcement across the districts. We've been dealing with public health in relation to outbreaks that we've had to deal with, and now we're looking at more prevention work And then we are currently looking at workforce planning to ensure that we are equipped to deal with any surges that may come through across the districts. We have got a mutual aid agreement across all the districts. So if we are to pull environmental health from one district to another, we've got that mutual agreement in place. And then the other quite big area at the moment for environmental health, and certainly for the city, are the universities returning to the city. And as I'm sure you've all seen, the statistics showing that the increase in numbers on positive cases are the 20 to 29-year-olds. So students feel most of that covert. So there is a lot of work at the moment. We've just launched, the county comms just launched the #Cancel COVID campaign yesterday, which is targeting at 18-year-olds to 30-year-olds. So I could go on for a lot of everything we are doing at the moment, but I will leave it there for any questions.
Thank you. So, Lorna, please.
Thank you. I'm looking at 2.9 in the report, which is talking about districts being asked to identify potential locations for local mobile testing units. We had a list of those recently circulated to us as members, and I advertised those locally because there were a couple in Ely. Having advertised those, I was told firstly by a resident who lives very close to Ely that they needed a test, but that they weren't offered a test in Ely, which was a mile or so from them, but they were offered the last available testing space in Norwich, and that earlier a colleague living in March had been offered a test in St Andrews, which is a round trip of 790 miles. We've seen nationally the concerns and issues around availability of tests and people offered tests in inappropriate places. For example, the Member of Parliament for Twickenham told the House of Commons that her constituents couldn't get a test in Twickenham if they entered a Twickenham postcode, but were able to get a test in Twickenham if they entered a postcode from Scotland. So my question is, and the other issue the local resident said was that the mobile testing unit that was supposed to turn up in Ely on that day never did turn up. So are the local testing units turning up? Are they being used? Are people locally being offered access to those local testing units?
Lorna, sorry, I'm awfully sorry to interrupt. Surely this is the district has been asked to identify potential locations. They're not responsible for the actual testing, are they? Yvonne, would you like to come back on that? Just to straighten that up for Lorna, please.
Yeah, we've been asked to find local locations for both types of testing, which is what we're currently doing across all the districts. The issue around the testing is a national issue, which isn't our responsibility, but it is a national issue that has been escalated nationally through the Health Protection Board.
Yeah, thank you. Liz, would you like to make a comment on that, please? Liz?
Yeah, so yes, just to say, Councillor Dupre, that we could perhaps address this question with the next item, the COVID-19 report, which does refer to the national testing situation. It really isn't the work of the environmental health officers.
Chair, can I just come back briefly? Yeah. My question was of reputational risk to this council, in that if we advertise sites that have been identified by districts and then are being used, that we then come up against a reputational risk if we advertise those and then people see them not turning up or not being offered tests at them.
I'm happy to take that with the next item. Yeah.
Yeah, okay, yeah, well, that's a really good point, Lorna, the reputational risk, and Liz will pick it up in the next item if we're happy with that. Yeah, thank you. Linda Jones. Linda.
Thanks very much. And thanks very much for this paper, Val and Yvonne, because it's extremely useful, and it's important to kind of lay bare the close relationship between the county and the districts and the way that the interdependence works in tackling local outbreaks. I must say I'm extremely relieved by the point that Peter made at the beginning, which I picked up as well, which is that the requirement that now exists for restaurants and cafes and so on to record information about customers. For me, sitting in the middle of Cambridge in Petersfield, just off Mill Road, is an absolutely a crucial issue in order to be able to trace those cases. And I think that I'm right in saying this is now a requirement. I would like to know how it's going to be policed, because one of the things that strikes me is I know, along with other cuts that councils have had to make, there have been cutbacks to some extent in environmental health as well. And I am kind of concerned that at the same time at national level, the Association of Environmental Health Officers is looking at how those roles might be extended and where they might be extended and so on. So I'm just wondering, have we got enough environmental health officers on the ground? Have we got big enough teams to be able to cope as the work of this group actually becomes more salient, more important?
Okay, yes, so just 2 points. First of all, the law comes in tomorrow with the contact tracing, and as yet, as always, we haven't been told who's going to be the enforcing authority on this. Is it going to be the local authority or is it going to the police? So we're waiting until tomorrow to actually know who's going to be the enforcing authority on that. In relation to staffing, each district has been given £150,000 from the county from the public health allocation, and we are currently employing, so certainly in Cambridge City, I've employed 2 environmental health officers to do COVID prevention work. So my intention, and I believe it's the intention of all our districts, that we will be buying in either qualified EHOs or COVID experts into the districts to be able to pick up some of this work. Certainly in the city, we are prioritising the COVID work, and we have already gone round knocking on businesses, telling them what they need to do, and basically saying to them, as of next week, if you don't do this, then you're breaking the law. So we have actively been going around in the city, but I do also appreciate that I've probably got quite a healthy resource in environmental health for the city. But I know that the other districts have also started appointing COVID prevention officers and high street officers to go around to the city, to go around to these businesses. So we've been doing a lot of work around giving education, advice, support to the businesses, and if we have to, we will instigate the 4th E, which is enforcement. But hopefully we won't need to do that. So
thank you. Thank you. Just move on now. The last I heard, and it was still under discussion, the COVID Rangers, whatever you want to call them, were going to be enforced by the local authority and funded by the local authority. Nothing's come back yet, which is saying that exactly, but I wouldn't be surprised. And also, I'd also like to take it further, but not today, to check with the other districts what they do with the funding we're giving them out the public health grant. It's really good to see you doing what you're doing with it. Liz, do you want to come in, please?
Sorry, Peter, I hadn't taken my hand down. But
slap.
I should have learnt by now.
Okay, Susan.
Thanks. Thank you, Chair. Just a quick question on 2.4, the paragraph on community support teams and the hubs. I wondered if we have a second lockdown and need to kick in these support teams again as they were operating before, whether we should expect to see a secondment of staff away from their normal day jobs to the support hub teams, whether at district or county level. And I hope I've understood the paper correctly. It's a concern about staff. Thanks.
I can pick that up again. Just quickly going back to your point, Councillor Hudson, on the other districts, I am aware that all the other districts are doing exactly what we are doing in the city. So all 6 districts have got the funding and have actually appointed into the prevention work of COVID. So please be reassured that's happening across all the districts. With regards to the communities, every district has also set up a rapid response team. So we've already got a rapid response team that each of the districts meet on a regular basis with their teams. That includes community hubs, community support, and also communications. And certainly we are working with the existing hubs to see what support we can give to people that have to self-isolate around giving food parcels, medication, and ensuring people can self-isolate. So we're looking at the journey of a person that's been positively tested right the way through to how we can support them. So my team would go out and do the contact tracing, give them the support, and then direct them to the community hubs. And as before with the shielding, each district has got slightly different modelling, but though that community has been stood up to allow for any surges that come through from now on until the future. So hopefully that answers your question.
Yeah, thanks, Yvonne. That's very good. Thank you. Jeff, please. Jeff, you there?
Yeah, I'm here. Thank you.
Oh, there you are.
Sorry. I just wondered whether there are any anachronisms in district councils granting of temporary event notices in relation to the prevailing government regulations on around COVID. And the reason I'm asking that, I haven't had my chance to do my homework on this yet, but I'm getting complaints in about abuse of temporary event notices. Actually, the complaint is around noise and the fact that more events have happened than have been allowed. But the locals are describing these as kind of raves in the wood, and I was quite surprised that any of that would be going on this year. So is there a need for more sort of tightening up between, well, hopefully the COVID regulations the government are issuing would have primacy over whatever the conditions for a temporary event notice are. But I wonder if you could comment on that.
So gatherings are illegal, and most of these gatherings wouldn't have even applied for a temporary event notice because they wouldn't have been issued one. So certainly from my experience, we've not really seen an increase in temporary event notices. The anomaly around temporary event notices is when we first reopened the high street, where people could actually drink off the premise when they didn't have a license to, because they got an automatic right to do that through the COVID work. But the gatherings, the raves and the big gatherings that are taking place more in the rural districts, they are illegal raves, which is a police matter. And they are illegal raves on a number of levels, but certainly on a COVID level now, there'll be more than 6 people. So that would fall under the COVID regulations.
Yeah, okay, Jeff.
Thank you very much.
Okay, great. Okay, Val and Yvonne, thanks very much indeed. We will be looking at this and keeping on this really closely, and it's been really good to hear what you've had to say, Yvonne, and of course you, Val. So thank you very much indeed, both of you.
Thank you.
Members. Although officers, we're going to move on to item 9, but officers supporting other service committees no longer have to bring a report on the COVID-19 response for their services. However, at a recent Chair Vice Chair lead member meeting, it was thought it was important, if not vital, for both this committee, which leads on public health, and for the public in general to continue to receive and be able to look at an update report from our Director of Public Health. A similar report will be brought to every one of our meetings until further such notice is given. And given the rapidly changing situation and the need to provide our committee and the public with the most up-to-date information, I have, of course, as always, accepted this as a late report, and I have to tell you what grounds I've accepted it on. The reason for lateness is to allow the report to contain the most up-to-date information possible. The reason for its urgency is to enable this committee to be briefed on the current situation in relation to the Council's response to COVID-19 for those services which it is responsible. Okay, so over to our ever hard-working and impressive Director of Public Health. Yes.
Thank you, Councillor Hudson. So I won't dwell on the report at length, but what I will say is that, as you know, rates of COVID-19 cases are rising nationally. And even with this report that came in 2 days ago, we're a little bit behind the national curve in terms of the information provided. So again, as you will know, a lot of that rise has been in the young adult age group. So the sort of 18 to 30 age group has seen the most rapid increase in cases. And the way that that's played out in Cambridgeshire is that we have seen a rise, particularly in Cambridge City, but also to some extent in South Cambridgeshire in those age groups. And we're very conscious of the need to address that. And in fact, I've been working closely with Yvonne as Environmental Health in Cambridge City and with others and with our communications team on a campaign very much targeted at 18 to 30-year-olds, quite a hard-hitting campaign to encourage COVID-19 safe behaviours. And that's just been launched, as Yvonne mentioned. I think it may be quite helpful to look at the graph in colour at the bottom of page 3 of my report, which actually gives you the rates of COVID for each of our districts, also Peterborough and also the national rate, right from the start of the pandemic. And you can see that the sort of dark red England rate is starting to kick up just between 21st of August and 31st of August, week beginning. That it's actually caught up with the Peterborough rate. Peterborough's been above average for a long time, but just now is similar to the national average. And you can see the light blue Cambridge also having gone up recently with those younger people. The other districts have Huntingdonshire, East Cambridgeshire and Fenland have stayed lower, but even since this report was written, we have seen some increase in Huntingdonshire and a little bit in Fenland. But on the whole, east of England is running at around half the national average for our COVID-19 case rate. So as a region, we're not going up at the same rate as nationally. And in Cambridgeshire and Peterborough, we are seeing a higher concentration of cases in our urban areas and a bit more stability in our rural districts. So that's the sort of overall epidemiology, and you can also look at the map on page 4, which shows where the highest numbers of cases have been. Our hospital admissions and deaths remain low, which may partly reflect that the cases are happening quite a lot in younger people. But clearly the worry is that as the rates increase, that spreads into the older and vulnerable populations. And then that would start to impact on the hospitals and ultimately mortality in the way that we've seen in other countries just starting to happen recently. So a focus of the public health response since I last brought a paper, we've continued, as you've heard earlier, just doing that routine outbreak management work with daily meetings of our surveillance cell and outbreak management team. With the rise in cases, which has been slower in Cambridge than elsewhere, but is still happening, you can tell from the people having to leave for outbreak meetings that we're busy with our incident management teams. And a little bit there in the paper about the governance. I would say that in Cambridgeshire, the biggest focus over the last month has been on the return to schools. So as said earlier, a lot of work around getting children back to school safely, but also around managing suspected cases amongst school children and teachers, which is an issue. And also we've had a big focus on working with our universities, with Anglia Ruskin and Cambridge University, on their plans for students returning, because we know that students are a high-risk age group, and some very good work going on with Cambridge City, with the universities and with our comms team, just to prepare as much as we possibly can to deal with that. We're also aware that nationally and to some extent locally, we're starting to see more cases in care homes, either through the asymptomatic screening of staff or in some cases through residents. So we're working with our adult social care and NHS colleagues to make sure we're implementing the care home support plan as absolutely as effectively as we can. And we're also working closely on events with our environmental health colleagues and the safety advisory groups. Finally, we're looking ahead to the winter and the potential impact of COVID-19 together with other winter viruses and the strains on the system that that could cause. So we're doing, we have a strong focus on forward planning locally. The national issues that have already been mentioned are the testing capacity being under pressure. And of course, I would be very happy to answer Councillor Dupre's questions about that and explain the situation more clearly. Locally. We have the new national guidance and legislation introduced last week around the rule of 6, around hospitality venues, and are working with our comms team to publicise that. And the government announced proposals on the 18th of August to create a new Institute of Health Protection through merging the relevant functions from Public Health England, NHS Test and Trace and a Joint Biosecurity Council. So that work has started, and I just wanted to raise it here because it has an important impact on the public health system nationally. So it's outside COVID, but the way in which that will play out in terms of the other functions of Public Health England is an important issue for this committee. So thank you for allowing me that time. I'll stop here and ready to take questions.
Thank you, Liz. Nikki, please.
Yeah, it's just a very quick question. What powers do we have as an area to invoke a lockdown or a change of rules? Do we have to wait for national guidance to tell us to do so, or can we invoke those as we feel it's necessary? And I'm thinking that because there's obviously our students are coming back into the city centre and all around the county, and I'm just concerned that I think we're going to see potentially a sudden spike, and if we have to wait until we're told to act, that may well be too late. If we look at what's going on at the north at the moment with Bolton, etc., who's been under special measures now for quite some weeks, which would indicate that maybe their measures aren't quite working at the moment. So I'm just thinking what kind of powers we have to go in sooner if we need to, etc.
Okay, so we have powers to close individual premises, public spaces, and so on. So we could close down for example, a venue where a lot of students were going and mixing and not social distancing. We could probably do something with a student hostel, though you would probably want the students who had caught the COVID to actually stay there and isolate rather than spread it everywhere else. So, but we have the powers to close individual premises and shut down events and shut down public spaces, but we don't have the power to lock down an area. Or to change the regulations. That has to be done nationally. What we can do is work very closely with institutions to work on the risk assessments together and to do sensible things. And we also have our very good local communications team and lots of ways of communicating with students and young people. So that ability to work in partnership, to communicate and to decide together to do sensible things can take us quite a long way in terms of what actually happens. And then, but in order to change regulations and put ourselves under special interventions like Bolton, I think our role would be to flag our concerns early and to have that dialogue with the National Joint Biosecurity Centre and with ministers to make sure that we intervene at the right point rather than too late. And I can say that we have daily communications on some of our areas of concern with the regional and national teams. So we are very closely linked in terms of having that discussion.
Thank you. Linda, please, Linda Jones.
Thank you very much, and thank you, Liz, for as always a very useful paper. I'm understandably nervous. My division encompasses 3 primary schools, 5 private independent schools, and Anglia Ruskin University, and a very busy shopping street with also lots of restaurants, which is Mill Road. So I do have concerns. I think I'm the sort of front line in terms of the situation getting worse. In relation to schools, could I ask how many testing kits. There was an article today on the BBC News site about the fact that a school had only 10 testing kits. And one of the problems was that when those testing kits were used, they had to start sending children home. So can I understand something about the arrangements that are made in relation to testing kits per school and the role of the local public health teams in doing the contact tracing? Because if the schools are trying to manage these things, they're not clearly experts. So that was one area. And the second area was the kind of support of GPs. Now, I heard earlier on Jan talking about the need to support GPs because they're obviously under pressure. But there was a Health Watch report which suggested that over 50% of GP websites didn't have the latest COVID guidance. And there was a kind of concern there that GPs were not keeping their residents up to date, which is an area that really could help people because GP is seen as a very trustworthy source of information. So both those issues, I know, Liz, you've been launching the Cancel COVID campaign. I'm delighted with that. I'm delighted with the change of regulations, but I just have these, these real worries about the situation going forward.
Okay. Thanks, Linda. So with regard to the schools and the test kits, that is a situation which changes almost daily at the moment. So schools were sent 10 test kits each, as you say, and the instruction to the schools was that those test kits should only be used when children couldn't get a test anywhere else through the Pillar 2 system. So only to be used sort of a bit in extremis. That advice has actually moved to those test kits can also be used for staff. Because clearly there's an issue if staff have to stay off, and in terms of the sort of whole school business continuity. The latest information that I've seen, although initially it was 10 test kits only, I have now seen information going out to schools telling them how to reorder when they run out of test kits. So that it is moving forward. But we all know that at this point in time, there is a lot of pressure on schools with a lot of winter bugs around and a lot of children and potentially teachers off with something that might be COVID, but probably isn't, but they still need to check because they have one of the 3 COVID symptoms. So that's a very active issue at the moment. And we are trying to put in some special arrangements where there's a risk that teachers being off will result in business continuity problems for the school. We're trying to do some local working around there, but that's very, very limited. So schools are of concern. There's a new helpline has been put in actually today from the Department for Education, working with the NHS Business Services Authority for schools to get advice on individual cases when they have a positive case in a school. So advice is coming in from that new helpline from Department for Education, but also schools are very well linked in with our Director of Education, John Lewis. So we're also asking schools to contact the local authority when they have a case or with specific issues. And the public health team works for, particularly Dr. Lakshman, who was speaking about childhood immunisations earlier. We work very closely with John Lewis to help provide advice to the schools that are experiencing issues. So yes, there is advice available, but it's a fast-moving situation, as it often is, as you get these big changes like the children going back. So that is the situation with schools at the moment, and we're doing everything we can as a local authority to offer that local support. And John Lewis is probably emailing school heads twice a day with the latest information and advice. In terms of GP websites, I also saw the Health Watch report, and I also saw some correspondence with the CCG, which was that with that information, the CCG would work hard to work with the GPs to promote having the right information on their website. So I know that action is being taken on that, and it was
Thank you.
Councillor Hudson, I think you're on mute.
Yes, I am. Susan, I'm sorry.
Thank you. My question to schools in my division are have faced this immediately in the new term, and it must be replicated across the county. And it is particularly staff who need to be able to be there to teach children. So do we have the resource that we need to be able to address the problem, I suppose is my question. And the resource that I've heard requested is a regular stream of test kits so that there's always a ready supply for staff, and or test site centers really designated for staff so that they can be guaranteed a ready test with a quick result. Do we have, are you able to give us a clearer sense of what we are able to do for schools, or whether there's a shortfall that is preventing that gap from being closed, and do we need more resource from government? Thank you.
Okay, thank you, Councillor Van der Ven. It is, as I say, a rapidly moving situation. And the first thing I'd say is that there's something that we can do by providing information and communication with the general public, and I think this is going out quite widely on national media as well. But there is pressure on the national testing system, the community Pillar 2 testing system at the moment. And we do know that some people are seeking tests when they don't actually meet the criteria. So there are some people who are going for a test as on a precautionary basis before they go back to work, before they go on holiday, or they are the contact, a close contact of a case of COVID-19, and they haven't been asked to get a test, but they still just want to check whether they've got it, even though they don't have symptoms. And actually, if you're a close contact, you have to self-isolate for 14 days anyway, and the advice is not to go and get a test. So I think one thing that we can do as a council with our very good comms team is to ensure that all the right messages are getting out there through as many channels as possible as to who really needs a test, because every time that someone goes for a test who doesn't meet the criteria, that takes away a test from someone who does and who has COVID symptoms. So I think that's probably one of the main things that we can do as a council, is to absolutely get those messages out there and make sure that the right people are getting the tests. That's a general point. If we're then looking at specifically at the schools issue and specifically at staff in schools, again, the same thing applies in terms of the staff having the symptoms and being absolutely clear who needs to get the test. But we know that there are staff who have the symptoms or who have a family member with the symptoms and therefore are not able to go into work. So that's going to be the vast majority of the people coming through. So in that case, the advice is for the teacher or school staff member to try hard to get a test through the Pillar 2 routes, through the dialing 119 or through the internet system, because actually people still are getting those tests. Our testing rates are stabilised, and quite a lot of people are still getting into that system. What we're then saying is you can look to the school and to the swabs that are sent to the school. We're not quite sure what the turnaround times are on that yet, and it's quite new. So our CCG colleagues have been extremely helpful and have said that where there's a really urgent situation around a school and some staff, they are working with some of the health service resources to, in a small number of cases, enable key school staff to be tested. And that's quite pragmatic, because actually if schools have to close, then that immediately takes out a lot more key workers, including NHS workers, because their children are at home, and that makes it very difficult for them to attend work in some cases. So what I would absolutely emphasise is that we are getting some fantastic partnership working from the NHS. around this, but that is extremely limited because there's only quite a limited number of tests in that system, which is not the national community system, and really should be NHS locally. So we've got some fantastic partnership work going on to prevent the worst happening in difficult business continuity situations, and John Lewis and local CCG colleagues have been very involved in setting that up. But I wouldn't want that in a sense too widely publicised, because it is quite a constrained system, but we have got something in place that helps our schools, and that is totally a local workaround. So it's not something that everywhere will have, it's just something that our good partnership working is doing in an emergency. And what we hope is that those national arrangements with the swab tests being sent directly to schools, I think we would advocate nationally for schools to be prioritised in the way that care homes are being prioritised and NHS is being prioritised around these key workers are really important for keeping the whole system going. So that would be our advocacy, Susan. But that's what we're doing at the moment. We're trying to do effective local workarounds with very limited capacity.
Okay, thanks, Liz. That's very comprehensive. Thank you. Lorna, please.
Yes, just the question I asked on a previous item about testing arrangements and mobile units and people being offered tests 400 miles away. Are they part of the national problems with Serco Test and Trace that we're reading about every day, or are they something local?
No, they're a national issue. So what's happened, and it's really good to get the opportunity to explain it, and I do apologise for your experience doing your best to publicise the local sites and then finding that the situation had changed. Nationally, there has been a big surge in requests for tests with the children going back to school and the more general upsurge in numbers of people testing positive. So there's a big increase in demand, and there has been some prioritisation towards areas which the government is most concerned about in terms of those areas of intervention with very high rates. So what's happened is that the mobile testing units and the drive-through testing units have stayed open, but the demand on the labs, which is the crunch point, because it's actually the labs where the capacity is not sufficient to meet all the demand. That demand is being managed by reducing the number of appointments at drive-through sites and mobile testing units, and particularly in areas really like Cambridgeshire where the rates are not so high and we're not a national priority. So that means that there is a more constrained number of appointments at our local drive-throughs and mobile testing units than perhaps there has been before. The other big issue is that we've previously allowed walk-ins at our mobile testing units and encouraged people just to turn up and walk through when demand was low, and nationally all walk-ins were cancelled. So all the units that are commissioned nationally, the mobile testing units and the drive-throughs, were told you mustn't accept walk-ins. So I'm afraid that what happened with yourself and Ely was just caught up in those sort of rapidly changing issues. We've worked really hard through our comms team to make sure we're getting the right messages out now, to the extent that they've gone back through all their social media from previous months and made sure that any posts that encouraged people to use the walk-ins were deleted. So we shouldn't have posts out now that are encouraging people to walk in. That should all have been taken away. But apologies for that situation, which developed very rapidly.
Okay. Are you happy, Lorna?
Thank you for the explanation, Liz.
Thank you. Mark, you've taken your hand down. Are you happy to keep your hand down? Okay. Thank you very much, Liz. So if we can go on to the next item. Oh, sorry, Linda. Linda Harford.
Yes, thank you very much.
Sorry.
I only just quickly want to ask something. Yeah. Obviously, we've all been working hard to try and support the vulnerable, particularly those who feel isolated and lonely. And I have to say that the new rule of 6 is proving to be very confusing. We've got some parish councils particularly that are more risk averse than others, and we are now moving towards a situation where some of the support groups that we have been trying to put in place to look after these people have been able to be held in the open air, but will need to move inside. And I just wondered if amongst everything else you've got to do, if there is any simple, clear communication that can be provided for parish councils and town councils and anyone who needs it. But for me, it was highlighted by parish councils, so that they don't refuse to open places, so that we can run these sorts of groups, rather than just because they don't understand whether or not they'll be in trouble for doing something wrongly. I'm sorry to add to your workload, but I do think this is incredibly important. Thank you.
I think that's a really important point, and very happy to take that away, Linda, and go through the relevant guidance, or ask one of my staff to go through the relevant guidance and produce some information for parish councils and others. Yeah, that's fine.
That'd be really useful. Thank you. Thanks for that, Linda. That's a really good question. Thank you, Liz, as always. And members, we're asked to note the contents of the report, which we have with great gusto, as you always do. So thank you, Liz. We move on now, please, to item 10, which is the agenda plan and appointments to outside bodies. So can I ask Dan, please, to introduce the plan?
Yeah, thanks, Chair. The agenda plan is as published. There's the item that was raised during committee that will be programmed in during the lead members meeting. And just a reminder on the appointments to outside bodies, I'll add the task and finish group and the relevant membership outside of the meeting.
That's great. Thank you very much. Are there any comments from anybody at all on the agenda plan? No, that's great. Thanks very much. So that's the end of the agenda. I really thank you for your attendance, and you've been cracking today, as you always have been. So I will now formally close the meeting. Stay safe, everybody. Nice to see you. Goodbye.
Goodbye.